Going under a slight name modification. A number of years ago, received feedback that emergency psychiatric services was a little bit of an outdated term. So we've been slowly dropping this. The problem that we have in Connecticut is people have identified us so strongly with EMPS as the initials. So we have dropped the actual full description, and our new name is EMPS Mobile Crisis Services for Children. And so that was just, and so the last rebranding that we did, 99% of our materials have just the EMPS Mobile Crisis. There's only a couple of pieces where it's still referred to as the full title because people always want to know what it stands for. But the next iteration will probably be dropping EMPS and just go to Children's Mobile Services. This slide is an important slide. It's a background slide that we used when we did our redesign. Connecticut's system really began back in the early 1990s. We had a major enhancement redesign in 2000, and then about 5 or 6 years ago, we did another huge enhancement. So developmentally, we got stronger and stronger. This is the same one we had last year. Yeah, you can shake it around. So what we redesigned 5 years ago, and it was in that time that we used some background data. And the most recent study came out last year is that overall hospitalizations for children did not increase in this period from 2006 to 2011. This is national data. But during that same period of time, hospitalizations for mental health conditions went up by 50%. So that's true of all of us, right? And ED visits for mental health conditions increased by 21%. And nationwide, $11.6 billion were spent on hospital visits for mental health. And any of you know who do a lot of work with hospitals, hospitals do medical stuff best, and sometimes they're very inadequately prepared for children. And sometimes the actual ED can be traumatizing in and of itself for a child. So this is where your bread and butter is, because you're spending a whole lot more at your local level in this area, and your mobile intervention could be your #1 ticket to divert these dollars. So we'll go back to a Connecticut-specific stat at the end of our piece here. Historically, you'll see that it's all a high-end cost with the deep-end treatment. It was in 2000 that we really expanded our array. It was our first children's behavioral health enhancement in Connecticut. That was really a major, and it was the mid-2004 to 2007 that we had a huge explosion of our intensive in-home array and evidence-based practices, and again, a strong enhancement of mobile crisis. And we've demonstrated over in particular the last 6 years, a huge reduction in the most costly reductions in congregate care, group home, and a huge transition of our use of kinship care in our foster care system. And so these were kind of a little bit of background. So our mobile crisis is, wow, this is going to be another one of those situations. Jumped a couple. No? Where did it go? Did you get forward? Yeah, so it's okay. Yep, it just wants to go. So I think we're going to have to. Yeah, actually, can you do that? Yeah. A couple things about our basic system is when we say team. So in Connecticut, they are allowed to go out by a team. But it's at their discretion. And what they find is they only go out a team in terms of when they think it's a dangerous situation. That's pretty much in a nutshell, and it's up to them. And we also have them have relationships with local law enforcement, and if they feel there's a safety factor, they also can have law enforcement, similar to what was described in the event that people had when the police are just even in the yard or kind of just there. So our primary responder doing the crisis intervention is a master's trained level and preferably licensed or on the way to being licensed. We use both bachelor and peer specialists as the second part of the team, or allow for that. We only have really one provider that utilizes that, and they utilize that only up on the follow-up, and we'll get to that in a few minutes. But essentially, in Connecticut, anyone in the state can call on behalf of a child in crisis. And depending on what the setting is, we have a variety of pieces of legislation that allows for intervention of a child in crisis, particularly in the school, without parental consent, although the best practice is to get the parental consent, and we'll get into that further. But essentially, it's a universal service. Probably the number one value that we place in Connecticut is that the crisis is defined by the caller, that if somebody is calling up a stranger saying, we need help, that is in fact a crisis. They're defined. We in Connecticut have this famous example of the quote-unquote peanut butter and jelly event where a mother called and said, my child is refusing to eat the peanut butter and jelly sandwich. This was a real call. And when we went out, in fact, it was this gigantic situation, and that was simply the tip of the iceberg. And so crisis, very often, if you are triaging to determine whether you should go out or not, you're going to miss a whole bunch of real crisis, and that will unfold more as we talk. Any child that's 18, if you're still in school, they serve up to 19, and then over 19, the child who's in the school system, the clinicians respond to the school, but it becomes a customer satisfaction relationship between the clinician and the school, because in Connecticut, over 19, we can't service on the child serving side, but the adult system won't go into the school. So it's a little bit of a catch-22, but they'll still see the kid. They'll just turn to the school staff and say, this is what we think's going on. They just can't, quote, process the case, if you will, under the 19-year-old. And again, it's available regardless of your system involvement, and private insurances are part of that, and we do bill. Not all the private insurances always pay. They say they do, but then they don't always, and so the providers do their best to collect. The only exclusions, if you're a locked facility, you're an inpatient or in a PRTF or the psychiatric residential and the subacutes and the residential treatment centers, any of those that have 24-hour staffing on them. Those are the only exceptions. We go to community-based group homes and any other setting in Connecticut. So our system is divided into a network. We have 3 components: the primary providers systems who are doing the mobile crisis. We have a single statewide call center, which people have heard about, and others here have a model of, and we have a statewide improvement center, and we'll go through all these 3 components. Essentially, we have 6 primary providers. State of Connecticut is small, and we'll show you a map in a second. They have 14 sites. That's approximately 170 with per diem and part-time. There's about 140 to 150 FTEs. And those are the ones we really work hard at workforce development on. You know, the conversations that were occurring, you know, many of the calls that people got snapshots on, very, very typical kind of crisis calls, right? And then your system is as best as the worker that you have out there right then. So workforce development is a huge issue for us in Connecticut, and we work really hard at that. The statewide call center, we used to use an old system, had 8 different numbers throughout the state. We had, despite having very strong criteria about what our providers were supposed to be able to do, very much as you described earlier, that if you have multiple calls coming in at once, they were saying they were capable of handling it, and when we discovered after the redesign, in fact, none of them were doing it when they told us they were doing it all along, and we had no way to demonstrate that they in fact were. That's one of the advantages when you go to a statewide call system, is your data and your screening and your assessment over the phone, the triage, all of that is much, much, much tighter because you're just dealing with one. And in Connecticut, it was our 211 system, which is our information and referral system, and so they became our statewide call center. And it's a warm transfer, so the call comes in, they take the information, and then immediately finds out where this call is coming from. They warm transfer the clinician in, and it's a instantaneous data collection system. It's a web-based. So all the basic demographics that are entered in by the call center, when they call the clinician at the local level, all of that's already plugged up in the system already, and so they don't have to double enter any data information. I'll get more to that later, but the clinical coverage, there's what we call non-mobile hours and mobile hours. Mobility, so it's 24/7, but face-to-face mobility within 45 minutes or less is from 6 a.m. to 10 p.m. And we'll get further into that. Performance Improvement Center is the third component. Again, there's a web-based data system. They do a lot of data analysis reporting. There's a standardized training curriculum, standardized practice, and there's an evaluation and data research arm that we've done a lot of things like this. So those are the three components, and I've started to jump into a little bit more so we can go to the next slide. So here's what we were talking about. Here's what the hours of mobility are. So what happened? What determines mobility right now? And the benchmark here is that it happens within 45 minutes or less. Is again the caller. So non-mobile, mobile, and deferred mobile. Non-mobile is the caller simply saying, I don't need you or I don't want you, or it's after hours and they're getting a master's trained clinician. When it's after hours, anytime after 10 p.m., the caller is offered the next face-to-face appointment. So at 6 a.m., they're offered a face-to-face assessment. So you're calling in, we're walking through the system. The crisis very often, what is that? Crisis all day, child just fell asleep, parents thinking, I got to call and talk to somebody about this. Sometimes they'll accept that, and sometimes they won't. So it may be just a phone only, but essentially that's that. They do have a huge, it's a call center, and they receive over 500,000 calls annually and 20,000 calls for us annually. So it's a large outfit. They're required to be mobile 9 out of 10 times. And so what, again, that means is once in a while, they have the right to make a decision that says this doesn't make sense to go mobile on. But they have to justify it, and or for whatever reason, they're not able to make that piece. And we'll give some examples of that. 80% of the 90% have to be in 45 minutes or less. And everything is reported through the data system, and so it's triggered by the call. The clock is triggered, and we build in brief windows for the, quote, the clock start to be ticking. This is Connecticut. You can get from north to south in an hour. You can get east to west in 2 hours. So we're tiny. So if you think about this proportionally for some of you bigger states, this would be magnified many. So this is a robust system. And in order to get to your treatment site, your service area site, you have to be strategic about where so we didn't dictate any of this in our RFP, in our procurement process. We just said that your whole service area, the service area is divided into 6, and then you have to place your sub-offices in a strategic location. Here to there, and here to here are the 2 areas in the state of Connecticut that as soon as you hang up that phone, you better be in your car because it's a full 45 minutes. So there's an area where they may not achieve that. Next. So we respond to anywhere the call is coming from, home, schools, emergency department, and in community locations, depending on the age of the child. But if they call and they're at McDonald's, the public library, we'll go anywhere. We do stabilization and follow-up. Diversion from the EDs is a really important piece. It's a primary area of focus, as well as law enforcement that we're doing a whole lot more with in this current. And in Connecticut, by law, new legislation, every single school district has to have a formal MOU with their local service provider for mobile. We have 202 school districts, and we have 137 memos of understanding, and the legislation is 2 years old. So you can see it takes some time of constantly outreach and knocking on the door to be formal about that. We also have done some data. We now, there's 2,353 schools in the state of Connecticut, school buildings. Now that number goes up and down every year because some schools add alternative schools and some schools close, but that's about exactly what our number is. In fact, we have a better data system on every school in the state than the State Department of Ed does, because we have to, our data system requires it, the location of every school. So we actually update that 2 or 3 times a year. We do a full clinical assessment. Follow-up, it goes for 6 weeks or 45 days. So what that simply means is that's only on the provider side, because a family could call at any time. But if you have an open episode of care, when the clinician leaves that person's house, they have a follow-up appointment. If they don't have a follow-up appointment, then we're closing out that episode of care. If they have a follow-up appointment, what that means is they now have the cell phone number of that clinician who's now assigned to work with that family for this episode of care, and that can go up to 45 days. So if there continues to be an acute crisis, or if there's some after effects to that acute crisis, they just call the clinician directly and they schedule and come out as necessary. They don't have to go through the 211 system. But if they can't get through, the family can go through the 211 system, and they're just connected to another clinician, but that's still that single episode of care. Why this only becomes arbitrary is it's really a paperwork issue for the provider. At the end of that 45 days, they have to have their full episode of care paperwork completed and in the system, and so it allows them to build that information as they need throughout. They have a full access to psychiatric services that we pay for, and in fact some of the docs or nurse practitioners will actually also go out and do mobile assessments. Lots of good collaboration, and linkage to ongoing care is probably our #1 priority. Yep. So standardized training, as I said, this becomes really, really important. Each module we deliver multiple times, morning sessions, afternoon sessions, evening sessions, move it all over the state so that it could, here's some of the core modules that we do. You'll see a couple things. The crisis intervention, that's our very basic standard on crisis intervention service. We do a lot with suicide prevention. In Connecticut, we believe that these folks should be the suicide prevention champions and assessors in the community, and that everybody knows who they are. I also happen to co-chair our state suicide prevention. We don't actually have a full coordinator, but I would be in that role, and I share that with the adult system. So we do a lot of crossover, and I know Guam and others have some interest in doing that. We have an emergency certificate, so they have to be trained on how to access that. Violence assessment, cultural and linguistic responsiveness. The disaster, we've had a lot of connection between the disaster, so if it's a natural disaster or some other event, they have to know how our system in Connecticut works. We've been doing a lot on this, particularly kids on the autism, the special population. So the disability community, both developmentally, intellectual, and the spectrum have been huge, huge areas. QPR, strength-based, traumatic events, and trauma. So here's the things that we've been focused on. These get updated every couple of years. We meet, we set the training calendar in July, set it all out for the year, and we update it as needed. We noticed that our data was showing that we really didn't make sense of the total number of episodes of care, that we were under-identifying substance use among adolescents. And so we've really added the SBIRT assessment, and in the first 3 months of this, man, our assessments have gone sky high, like increasing by 70%. So we're seeing a huge benefit from SBIRT. And the newest thing that we're about to embark on, and we're trying to keep the providers from being overwhelmed, is we're also under-identifying intimate partner and family violence, and so that's where our next area of focus is on workforce development. So phone only, about 22% of the entire episodes of care. Face-to-face, 46% of all episodes. This is the total 100%, and that first what we call one and done. So many of these just have that first acute visit and don't have any follow-up. That's about 46%. And they can go out multiple times between 1 and 5 days. So we refer to that as quote-unquote one and done, but it really could be multiple visits up until 5 days. If it goes beyond 5 days, they're automatically in that follow-up phase that they have different additional paperwork. Again, it's streamlined assessment and intake process, and we have some best practice when we get into that. I believe it's tomorrow. And stabilization and follow-up, so that past 5 days up to 45 days is about 32% of all those. Again, we go through this same process, and again, there's no limit on the number of episodes. So a child, we literally track the data. I think we had a child last year who had 22 episodes, separate episodes of care. That was our highest. So we mentioned the 170. The 6 regions, literally the 6 providers who won the award when we re-procured 6 years ago were some of our strongest providers and had the largest continuum. So when we connect to care, very often they're referring to self in either intensive in-home array, intensive outpatient, et cetera, or there's plenty of their, where their projects are, their satellites are, that they are not in that area, so they do connect and refer out to others. But that basically, they're pretty our strongest our providers. This is the clinician level. There's the director, psychiatric consultation, family partners on some teams. And we do prefer the team response, but again, most of the time it's non-team. So that's the basis of the model. Is there any questions? Because we're going to go through the data and then we're going to go through some of the outcomes. And as we go through that, it will illustrate the model a little bit more fully. Okay, great. Thank you.
So Tim mentioned that there are 3 components of our model or our system in Connecticut. One is the provider network themselves, the 14 sites. The second was the statewide call center, which operated by 201. And then the third was the Performance Improvement Center, and that's my piece. So I oversee the Performance Improvement Center, and we're responsible for the data analysis and reporting, site-based quality improvement activities, and all the training and workforce development for the whole statewide network of providers. Okay, so I'm going to go through the data and talk a little bit about what we find, what our population of children and families looks like served by EMPS. As well as some of the outcomes and other work that we do. So as you can see, most of the kids that are served by EMPS are in the adolescent range. So about 2/3 of kids are between 13 and 18 years old. If you look at our population according to race and ethnicity, about 58% of kids, I'm going to be going back, preventing that flip to the next slide, but about 58% of kids served are Caucasian, about 18% are, or 21% are Black, African American, and then I think this slice here, 18% is actually other race. Okay, so you can see the numbers and what that looks like. That's approximately close to what the Connecticut broader population is. In terms of ethnic background, we find that about 27 to 30% are reporting Hispanic ethnicity. That breaks down according to mostly Puerto Rican heritage, some Cuban heritage as well. Part of the reason I'm putting up these slides in here, I wanted to make the point that what we find when we look at the EMPS system compared to other parts of our mental health system, you might find underutilization in the behavioral health system according to, for African American and Hispanic youth, proportionate to the population. We actually see the opposite in our mobile crisis system. We see that that system actually reaches those populations at a higher rate than you would expect compared to their proportion of the general population or even the Medicaid population. And I think that's an important point to make because part of the reason you have a mobile crisis service is to go out there and meet the needs of the community. And some of those access barriers that traditionally impact communities of color are really mitigated by having a strong mobile crisis system. So we find that the utilization actually looks better among some of those populations where if you look at other parts of the system, it might look like you're underutilizing the system. So I wanted to make that point. So when you look at our population, Tim mentioned that our system is somewhat unique in that it'll serve all kids regardless of commercial insurance, Medicaid insurance, anyone who calls. They don't even ask the question. EMPS goes out regardless of insurance type. And a family never gets a bill in the mail, even if it's a commercially insured family, that they don't get a bill or a copay or anything like that at the back end of EMPS coming out. It's offered free of charge for all families. So about 65% of kids who are served in our system are enrolled in Medicaid. A little bit more than that, different Husky options. Husky is Connecticut's Medicaid system. And almost 30% are privately insured. In terms of presenting problems, this is kind of the breakdown according to the 6 regions, but on the far right side is the statewide level. And if you look at the top 3 presenting problems, you can see harm or risk of harm to self, disruptive behavior and depression makes up about 68% or so of all presenting problems coming in. So that gives you a sense about the types of issues that are coming into the mobile crisis system. We've also done a lot of work in the state of Connecticut to make our behavioral health system more trauma-informed. So that's part of the training that we do for our EMPS system, and we also have a number of trauma-informed evidence-based practices. So there's a lot of sensitivity around issues of trauma in the state of Connecticut. And we find that about 65% statewide of kids who are served by our mobile crisis system have experienced at least one traumatic event, and oftentimes many more than that. So if you look at who's referring to our EMPS system, the two biggest referrers for the last several years that we've been collecting data has been pretty consistent. About 40% of all of our calls are coming from schools, and 43% from families, or occasionally from young people themselves, but that's mostly parents and caregivers who are calling. So that makes up about 83% of all the calls coming in. Sometimes we get the question, and some people set up their mobile crisis services and say, like, we don't want to open it up to schools because we're afraid that they're going to call us. We've heard that before from people. And our response to that is, yes, you're correct. If you allow schools to call you, they will call you. And they do. They use the system a lot. But in our estimation, that's a very good thing. If that school is not calling EMPS, who are they going to call? Police. Ambulance. So again, those are kids who are ending up in the emergency department or in the JJ system. So our mobile crisis program provides a really important diversion function from juvenile justice and from emergency department and maybe even an inpatient hospitalization. Okay, so you saw there was a slice of that pie for emergency departments. These days, about 9% of all of our referrals are coming from emergency departments. There are two different ways that the EDs use the EMPS system. One is when a child appears in the emergency department and they kind of do the evaluation, and then they're looking for someone to come out and help link that family to community-based care after that emergency department episode. So that's pretty common. The other way that they use it is for an inpatient diversion. So that would be somebody's making an early determination when a young person appears in an emergency department that, you know what, this is a kid that might meet level of care criteria, but we're going to try to maintain this kid in the community without going to an inpatient hospitalization. So we're going to call EMPS and have them kind of take this case from us. So those are the two ways that EDs use. As you can see, percentage-wise, that EDs have used the EMPS system, percentage-wise, a little bit less, but the actual total number of kids that this represents is pretty consistent because our system has grown so much over time. So this slide kind of shows you overall utilization of the system over the last several years. As you can see, there's been a pretty steady and consistent increase in the number of calls coming into the system. The red portion, or the portion of calls that come in that end up getting screened out, they never go to an EMPS provider. So 211 gets the call. It's sort of that I smell gas in my basement kind of call. They get screened out. The remaining calls here in blue all are EMPS episodes of care. And this represents duplicated counts of kids. Okay, so this is episode data here. So that tells you a little bit about, actually there's a data error here. That should be 75% and that should be 76%. First time I've seen that, caught that at least. So that shows you the total number of calls and then the proportion that turn into EMPS episodes of care. Okay, the other thing that we do is we look at utilization of the EMPS system standardized for their population. So for each of the 6 service areas that Tim mentioned, from census data, we can get their 0 to 18 population of children, and we standardize the number of episodes that they see relative to their population. So because every service area's got a different population of youth, it might look like if you just look at raw numbers, some providers are really busy and others aren't. This helps you kind of look at this from the perspective of what does your productivity look like relative to your child population that you serve. So you can see when you do it that way, we set a benchmark for the year. We want all of our providers to see 2.5 per 1,000 children in your district. Again, this is data that we had to sort of start with a number and see where it led us. It's turned out to be pretty good. So that shows you a little bit about what utilization looks like statewide and across the service areas.
I would just add that slide. So we require, your system is only as good as how well do the citizens of your state know it. So we require them at a contract baseline to do 2 outreach activities every month or 24 annually. If they fall below this benchmark, we require them to do 1 a week or double that. So what that just says is some reason the people in that community may not know they could utilize it more. So, and we have plenty of the outreach activity to monitor that.
Right. A second major performance indicator in our network of providers is mobility. We showed it on an earlier slide. We want, for every call that comes in from 211 saying, we want you to provide a mobile response that goes to the provider, at least 90% of those calls should get a mobile response. We give them that 10% wiggle room for situations where they don't have a clinician, everybody's tied up, but we want at least 90% mobility in our system. And we found, it started out, this was before we started collecting robust data and reporting it back to providers. It used to be that the system was getting about 50% mobile response. And as you can see, as soon as we started collecting data and tracking this and reporting it back to sites, performance went way up, and it stayed over 90% statewide for the last several years. And we look at that at the statewide level. We also look at that data for each one of our service areas, so each of the 6. We can also look at it for all 14 of our sites individually, so that each site knows exactly where they stand on our performance benchmarks, which tie right back into their contract deliverables and back to their program goals. So there's a lot of alignment from the program goals to the contract language to the data that's reported back to them, all kind of feeds in to each other. So as you can see, data is a really important part of our system, and we use it a lot. The other benchmark, or one of the other benchmarks we mentioned, was response time under 45 minutes. So we want, for every mobile response that takes place, we want them to be there in 45 minutes or less. And the benchmark for that was 80%. So 80% of all mobile responses in 45 minutes or less. We started out at around 62% when we first started, and we've been well over 80% and now approaching 90% for the last couple of years. So we're really pleased with that. The median response time for all responses in our statewide network is about 25 minutes. So we do really well on this indicator.
How do you measure?
So the time that the 211 receives the call, they enter in the date and time that call came in. Okay? And then when the EMPS provider goes out and provides a mobile response, when they get back to their office, they have to type in what time they arrived. We just subtract the 2. We give them a little bit of a cushion because of the few minutes that they spend on the phone doing the warm transfer thing, but and then we hold them to that 45-minute standard. So that's how it works. It's all through the data system.
The average length of a phone call is 4 minutes.
We actually give them a 10-minute credit, so we're very generous with the credit, even though the average is about 4, and we're getting good performance on that data. So there are very few complaints that nobody showed up for 3 hours. It just doesn't happen very often because they know they're going to get a report at the end of the month showing them exactly how they did. And by the way, every single provider, and I was going to get to this later, every single provider sees everyone else's data. We share all the data transparently with every provider. Nothing is sort of blinded. Here's your site's performance on this. They get to see what the statewide averages are. They get to see what the provider next door is doing, and if they're doing better or worse. There's some healthy competition that takes place among sites, which we think is a good thing. So that has worked out pretty well. We also measure for those kids who get the longer stabilization follow-up episode of care. So for about a third of all the kids that are seen by EMPS, we'll get sort of that longer, up to 45-day episode of care. And they get an intake and a discharge measure on the Ohio scales. That's the assessment or outcome measure that DCF has adopted for most of the behavioral health services. And as you can see, we have, this is just from 2016, there are 300 completed measures by parents and over 3,000 completed measures by workers, so by clinicians. And we see significant increases in functioning and significant decreases in problem behavior for the statewide network. All of those are, and we also look at clinically meaningful change. So on the Ohio scales, you can look at whether it's just statistically significant or is it actually clinically significant or clinically meaningful. And somewhere between 7 and 16% are reporting a clinically meaningful change in the Ohio scales from intake to discharge from the system. So we've always been a little bit surprised by that because the EMPS is a brief, crisis-oriented system. Really the focus is around stabilization and linkage, but we're seeing a lot of symptom reduction from that you might not expect from a brief crisis-oriented response.
I was going to add one point. As we do different performance improvement activities, you shine the light on different areas at different times, right? We've done this one a number of times. So when you see this worker and this is the parent, when you shine the light on this and you really put them pressure on this number shoots way up. And then you go somewhere else and that number goes up and then this one goes down. So it's an area when you constantly, it's why really using their data on a monthly basis, we meet with all the managers every month, go through all their data, and if we see any anomalies, we'll just talk about that. And so we'll do 2 or 3 different kind of performance targets. They have to choose one a year themselves, a minimum. Sometimes they'll choose 2, but we'll shine the light at different moments and again see those things improve.
So what we hear from our providers is that it's really difficult to get the parent discharge measure. So we have a lot of parent intake measures, but we don't have the paired discharge a lot of times. And that's because many of you who are doing this work probably understand that there's a lot of unplanned discharges in mobile crisis work because you stabilize that crisis situation and then you call for a follow-up appointment and the family says, you know what, we're doing pretty well right now, we don't need you to come out anymore, and then you never get that follow-up measure. So we work on it and we do the best we can to get discharge measures, but it doesn't always happen. So we were asking, or we were talking earlier, we've got a couple more minutes, so I'll try to finish up here. At the back end of that EMPS crisis episode, one of the goals is around linking those families to ongoing care. So about 41% of all episodes at discharge get a referral to outpatient services. This one says 23.7% no referral, but that's a little bit of a tricky category because that also includes families who already have a provider and the EMPS refers back to the existing provider. So that 23% is an inflated number. I think a large majority of those are going back to families that are already connected to some other provider. And then you can see how it works, what the referrals look like: intensive outpatient services, other community-based care, and Tim mentioned we have a really robust intensive in-home evidence-based practice service array that gets referred to a lot. Average cost of an inpatient hospitalization stay, average cost of an EMPS episode of care. Okay, so big difference. If you take a look at the number of kids who are diverted from inpatient and multiply it by that cost savings, you find that you save, in fiscal year 16, we saved over $2 million to the Medicaid system by diverting kids from inpatient. That doesn't even take into account the number of kids who are diverted from the emergency department to begin with, number of kids who are diverted from the juvenile justice system, and other high-end levels of care, as well as savings to the commercial insurance industry, which we talk about a lot. So that's another piece of information to take into account. We'll forego these slides on lessons learned, but we're available to talk to you a little bit about that, and we've learned a lot in this process and are still learning every day. So thank you very much.